We also have another group set of disease we call opportunistic systemic mycosis. These are fungal agents in the normal circumstances that are what called they can coexist with the host and be classified under the normal flora. But when a situation arises which is affecting the host, affecting the immune system of the host, then these fungal agents establish themselves as disease causing pathogens, hence earning the name opportunistic systemic mycosis. Opportunistic systemic mycosis.
Okay.
So, under this category, we have diseases like what we call candidiasis. Candidiasis is a common infection caused by Candida albicans and the related species. So we have the Candida, the genus Candida fungal agents. The most common Candida species in the Candida that causes candidiasis is Candida albicans. But there are also others which can also contribute to that. Then we have another group we call Cryptococcus. This Cryptococcosis, it can be common or rare depending, but it's caused majorly by fungal agent called Cryptococcus neoformans. Then we have this aspergillosis disease, majorly caused by Aspergillus fumigatus. We also have other group we call a disease called pyrehydrophomycosis, pyrehydrophomycosis, commonly caused by cladosporium, zoophila, ongelia, bipolaritis, exorrhizum, sacavillaria. But this kind of fungal infection is very rare, rare indeed. You can also have pseudoleishmaniasis, caused by Pseudoleishmania boydii, but also very rare. We have zygomycosis, commonly caused by fungal agents like Rhizopus, Mucor, Mucor, Absidia, etc. Then we have hyalohydromycosis, caused by fungal agents Penicillia Mycoses, Beuvraria, Bassiana, Fusarium, and all that. So this I'm just mentioning for your noting, but there are a few which at the tail end I'll show you the medically the ones which are for exam purposes. Some of them is just good to note that they exist. So this cryptococcosis is a chronic subcutaneous subacute to acute pulmonary disease. It is systemic. Once you inhale it, have it, it can spread to the meninges, causing what you call meningitis disease. And it is initiated by the inhalation of the basidio-spores or the scattered yeast cells of these C. informants. Um, Primarily, it has no diagnostic symptoms, which are usually subclinical. We could be having them like even as we speak, but as long as your immune system is strong, it will not cause anything. It will be restricted. It will be cleared from our systems. But whenever it gets a time to disseminate, it becomes a very dangerous fungal infection. And the first thing it does is that it affects the central nervous system, though the skin, bones, and other visceral organs may also become involved, but it spread easily through the central nervous system. That's why you'll find it in the meninges. Um, how does it present itself? Cryptococcus is an encapsulated basidiomyces yeast, is an encapsulated basidiomyces mycetes yeast, which once you inhale it, it have the tendency of wanting to spread through the central nervous system. Two major species that cause cryptococcosis is what we call Cryptococcus neoformans and Cryptococcus gatti. So C. gatti and neoformans are the most common ones. They can only be distinguished using biochemical tests, other or molecular work, a technique. Otherwise, presenting it physically through symptoms, you cannot differentiate them. So C. neoformans mostly affect immunocompromised hosts predominantly, and is the commonest cause of fungal meningitis worldwide. Around 10 to 10% of patients with HIV are affected. People who are really compromised with persistent cough and all that, patients, doctors will quickly ask for this check of Cryptococcus disease, because once it spread to the brain, you are a finished guy. But once we treat and restrict it there, you live long. So you may realize as you graduate going the field, most of the HIV positive people, once a doctor senses is having common persistent cough, you will see there they're saying check for Cryptococcus neoformans. You will just know because of the immune system is low and being an opportunistic fungal agent, it must be checked, controlled, otherwise it can cause havoc. Meningitis, the predominant clinical presentation with fever and headache as the most common symptoms for somebody having this cryptococcosis, especially in people who are immunologically challenged. From there, we have secondary cutaneous infection, which occurs in up to around 15% of patients, where the spread can move on. But at this moment, prognosis is not clear. Lesions usually benign, a small papules subsequently ulcerative may develop, even abscesses, erythromatous, nodules, cellulitis. This variety is found worldwide. So in contrast, the distribution of these cryptococcus um, um, or compared to Cryptococcus gatti is geographically restricted and is not really found only in immunocompromised hosts. They affect anybody. Large lesions in lungs and brain are characteristic, and morbidity from neurological disease is high. That is for C. gatti um, is not restricted. It's endemic in Australia, parts of Africa, Mediterranean region, India, and all that. So, presentation of clinical presentation of this cryptococcosis. First, we have pulmonary cryptococcosis. When your lungs are affected first or infected, you don't show symptoms, and therefore it becomes the carrier and spread to other people or spread to other parts of the body. Um, During this time of pulmonary tuberculosis, you can experience a lot of sputum, productive, skin is healthy, so you may not so much see anything here, but progressively somebody will become having chronic lung disease such as bronchitis and bronchiectasis. Um, so at this point, if there's no disease, um, i- diagnosis, the patient will now start experiencing more serious conditions like cough, lesions could be developing inside in the lungs. And then if that happens, you start having what we call chronic granuloma, which are forms in the lungs. And this increases the risk of the central nervous system being seriously shut down. If that happens, if there's no disease, no treatment at that level, so the pulmonary conditions will proceed or spread to the central nervous system as a clinical syndrome of this cryptococcus disease. Once it reaches the central nervous system, it is spread to the brain and the meninges, which is now becoming the most common clinical manifestation of cryptococcus and includes inflammation of the meninges, that's meningitis, meningoencephalitis, inflammation of the brain, expanding, cryptococoma. So something in terms of like development of mass or nodules in the brain, the swellings, you know, mimicking the cancer, or tumor in the brain. So it becomes common, especially for people who are HIV positive or immunologically compromised. Um, these signs and symptoms can develop over several months. It's not a 1 day or 2 day thing. It's really progressive and gradual, but it's a very very dangerous disease if no disease treatment is done. So slowly somebody will start having persistent headache, drowsiness, dizziness, irritability, confusion, nausea, vomiting. Because once the nervous central system is affected, many things come in. And then therefore, when you start experiencing neck stiffness, then know that really the meninges have been affected. And that's a dangerous sign. Within a short time, if there's no quick attention, you lose somebody and all that. So those signs and symptoms will persist on, and you realize that somebody will now be not easy to respond to drugs. The best thing now to do at that time is to do some MRI scan, whether it can be possible to show some multiple cryptococcus white masses in the brain. Though rare, but it can be identified. So the symptoms will pass if it persists only, it will go into intracranial mass that include headache, drowsiness, nausea, vomiting, mental changes, slurred speech, double vision, and all that, and steadiness. This becomes now more chronic, clear signs and symptoms, uh, you know, for this kind of disease. If no treatment, it will now metamorphosize into what we call cutaneous cryptococcosis. And here, principally, is presented by ulcerations, um, and the lesions may resolve spontaneously with systemic antifungal treatment if they are treated here. But patients with the skin lesion should be monitored carefully so that no possible dissemination of this disease to the central nervous system, which is very dangerous. Once it reaches there, it kind of captures the immune system of the patient. From there, especially, it can also cause what we call abscesses, nodules, sterilitis. But patients with AIDS, the skin manifestation represent the second most common site of dissemination of cryptococcus. That's after the lungs. When you people who are HIV positive, you see this kind of thing. Skin manifestation, the skin are affected, scales, badges, comes all over. You should also consider now doing a test on this. Nodules form ulcers, abscess and all that. And this can also come into what we call molluscum contagium and Kaposi's sarcoma. Anal ulceration may also occur. So, that's why we are calling it systemic. It spread once from the lungs to all other parts of the body. Okay. Then we have this cryptococcus, of I'll see it later. This kind of uh, cryptococcus occurs in up to 10% in cases where it involves the what we call the bony prominences and the cranial bony and the vertebrae. Those are the key areas that are affected. The lesions are lytic without periosteal reaction, but the pain, start bothering, especially the joint also. From that, we also have what we call ocular cryptococcus. These are now syndromes. This occurs mostly common include papilledema, where the eyes are affected with the some retention of the fluid within the retina, causing optic atrophy, affecting the eyes due to intracranial pressure. And this, though uncommon, but it can easily disseminate to other parts of the body. Then we have other forms of cryptococcus. Neoformans is obtained from urine of patients with disseminated infection, can be realized. Clinically, we can have CSF as our first priority sample to check if the central nervous system is affected. You can do biopsy, tissue, sputum, bronchial washings, etc. Interpretation, check for encapsulated yeast CS cells in CSF or biopsy tissue. Um, Basically, all patients with positive microscope for cryptococci from any site should be investigated to disseminated disease, especially doing culture. Again, for this one to be do it in what we call a lab as well as a septic cabinet. You can do identification. Once you identify, there are other common species other than C. Gatti. We also have Cryptococcus albidus, laurenti, you know. So those are the common causative agents, but we've been able to look at Cryptococcus neoformans. Others mimic the same appearance. When you talk about aspergillosis, is a wide spectra, fungal agent that is in a member of the genus Aspergillus. This includes mycotoxicosis due to ingestion of contaminated food, allergy and sequelae to the presence of conidia, you know, from the then colonization without extension is performed in the cavities. We have invasive inflammatory granulomatous narcotizing disease of the lungs because of this the Aspergillus species. It can also be very patho systemic disease. The most common etiological fungal agent that causes aspergillosis include Aspergillus fumigatus, A. flavus, A. niger, A. nidulans, and A. teresias. Terias. So these are the common agents that can cause aspergillosis. It can cause pulmonary aspergillosis, which includes allergic reaction, aspergilloma, formation of nodules or mass in the lungs, and invasive aspergillosis that spread to other parts of the body and organs. It can manifest as um, through what you call pulmonary aspergillosis. We can experience allergic conditions, what is what we call quantum of clinical entities, ranging from intrinsic asthma to extrinsic allergic alveolitis, where the alveoli are affected in the lungs, causing serious allergic reaction manifested to the skin and all that. Also, you can have bronchopulmonary aspergillosis, hypersensitivity pneumonitis. Here, somebody coughs all through, and that's why um, sometimes, really, we can confuse fungal agent with the bacterial, giving somebody a lot of antibiotic and missing the target. And by so doing, we will be able to, you know, to miss the target. So from pulmonary, we also have other non-invasive Aspergillus or Aspergilloma caused by saprophytic colonization of the preformed cavities, which could be secondary to tuberculosis, Thank you. So we can also have disseminated aspergillosis, you know, like that, cutaneous aspergillosis, lab culture interpretation, identify. Then